Okay. Well, good evening and welcome to our Sci-Fi night. And we do have a planetarium show at 8 o'clock. Our observatory is open until 10, assuming the clouds will cooperate outside. Saturn is up tonight. If you haven't seen Saturn through the telescope, it's a crowd pleaser. It's always beautiful. And it won't look good until about 8:30ish. So when it gets dark out there, you'll see it coming up. It's really pretty. The museum, by the way, will be open until 9 o'clock. If you want to wander around the galleries and see the new exhibit, that'll be great. I'm David Dundee. I'm Director of Education. I'm so glad you've come here this evening. Our next Sci-Fi night is on October 6th, and our own Jose Santamaria, our Executive Director, is going to be talking about 52 million years in western Wyoming, and he's going to be talking about rock collecting and some of the ancient lake beds of western Wyoming, so you might want to be here for that. That'll be great fun. I also want to tell you about a new something that's going on, and that is one of our geology program manager, Hannah Isla, is on her way out into the ocean in October. She's on a research vessel and doing geology on the high seas. It goes from Iceland to the coast of Europe to Amsterdam. And during that trip on Saturday, October 21st, she's going to do a live hookup here to the museum, and we get to take a tour of the ship, well, virtually, and get to see the ship and some of the inner workings of the coring crew, where they actually do deep cores under the ocean with these research vessels. So it'll be a fascinating adventure there. On October 14th, we have Heavy Metal in Motion, not a Led Zeppelin concert, but it is actually bringing big machines to the museum. And so we have everything from helicopters, SWAT vehicles, big road building equipment. We have an airport tug coming, and the airport equipment that takes your bags and puts it on the plane, those big conveyor belts. Well, you see them from your plane window, but you get to see it up close. We have fire engines coming. We have a life flight helicopter coming. Let's see, what else? We have agricultural equipment coming, all sorts of cool stuff. Oh, we actually have a demonstration that day of personal electric vehicles. This is a new venue for getting more patients for our speaker tonight. These are actually electric skateboards, electric scooters that are becoming very popular and would quickly send me to my nearest orthopedic surgeon, I think, if I got on one of those. But anyway, we're having it. And that particular day, folks, we've also scheduled a partial solar eclipse, and that will be going on here at, it'll be amazing what we can schedule here at TELUS. And that will be going on during the event. And even if it's cloudy, we'll be streaming the eclipse here into this theater. It's an annular eclipse, not annual, but annular. So the moon is just a little bit too far away to cover the whole sun. So at the mid-eclipse, it looks like a ring of light around the sun, an annulus. And so here in Cartersville, it'll only be a 51% eclipse. But to see the annularity, you have to be out west. But we'll be able to live stream it through NASA TV, and you'll see it here. So that'll be kind of fun. Our next Lunch and Learn, by the way, if you're here during the day, is on October 25th, and we'll have the president of the local company, Patrick Phillips, who is promoting and selling personal electric vehicles. Again, the skateboards and scooters that are flying around the street. That's for a young person, obviously. For if you have some small folks in the house, we have Batty About Halloween Science. That's on October 28th. We'll have all sorts of great Halloween science experiments, interactive science experiments going on here at the museum, and also some Halloween treats. So come that day. It will be amazing. And if you like comedy, we have stand-up comedy here at TELUS. Believe it or not, Georgia Tech has a troupe of scientists that are in a stand-up comedy group, and they are coming to tell us on the 29th, and you can come and enjoy science and comedy. It's for 21 and up, because we'll also have some spirited drinks there that night as well. So also we have a workshop coming up on September 22nd. If you want some personal time in the observatory with our astronomer and some of our education staff, those are for smaller groups. We do these workshops, and that will be on the night of September 22nd. So all sorts of cool stuff coming up here at the museum. Well, tonight I have the great honor of introducing Dr. Ben Barden, and he is going to be talking about common sports injuries tonight. And he is an orthopedic surgeon. He treats patients of all ages, specializing in sports medicine, and joined Peachtree Orthopedics in April of 2023. He's a board certified by the American Board of Orthopedic Surgeons after graduating from Emory University School of Medicine. Dr. Barden completed his orthopedic residency at Steadman Hawkins Clinic of the Carolinas, and then completed his additional specialty training in sports medicine at the University of Connecticut. A winning basketball team, I think, up there. And his training confers an expertise in minimally invasive arthroscopic procedures of shoulder, hip, knee, and ankle. In addition to orthopedics and fracture care, his clinical interests include patellofemoral dysfunction, which I think in my amateur medicine means patello means knee and femoral means something to do with the femur, right? Okay, I'm in the right department, okay. And complex shoulder and knee injuries, so evolving to cartilage restoration. I want to also add a personal note. Dr. Barden comes here under great personal stress. He agreed to come up here, and then a few days ago he emails me and goes, "My wife's not speaking to me because I was supposed to be at Temple tonight. It's Rosh Hashanah, and there was going to be a big thing tonight, but I promise I'm going to come." Then about a half an hour later, the next email, which is signed Terrible Father, because he also forgot that tonight is the birthday of his 11-year-old son. So I felt bad that he's coming up here, rushing up here to do this talk and going back to his family who's probably not speaking to him. So I wanted to present Dr. Barden with a birthday present for your son, some science from TELUS. They will speak to you again. So with that, let's have a big welcome for Dr. Barden tonight.
Appreciate it. So my name's Dr. Ben Barden. He's right, I'm an orthopedic surgeon, and I did my fellowship in sports medicine. We'll talk a little bit more about that, because I really think sports medicine is a misnomer in terms of what we do in that specialty, and I'd like to educate you all about it. But growing up, places like this were really exciting for me, whether we were traveling on vacation or, I grew up in New York, and so there's tons of small townships. We would always, seek out, whether it was youth-oriented or adult-oriented, science museums, especially the ones that were hands-on. And so when when David emailed me, months ago saying, "Hey, we're looking for someone to do a lecture associated with this new Sportsology exhibit," I got really, I was honored, and I was very excited, so I quickly checked my work calendar, keyword work calendar, and it showed no conflicts. So I was like, yeah, I'm down for it. And the date, September 15th, should have right away set off like, oh, sorry, can't do that one. That's my son's birthday. So luckily his birthday party was last week, and so I ran that show, and he's a wise soul, and I told him that Daddy screwed up, and he was so sweet. He's like, well, we can go to dinner Sunday. So he was very understanding, but then I did forget that, there's like, even if you're the most non-observant Jewish person, you go to at least 2 holidays a year, and it's Rosh Hashanah and Yom Kippur. So there's 38 of my wife's family down by Piedmont Park at my aunt's house, where it's a special Rosh Hashanah, because apparently it's Music Midtown, I think they call it, or So like Pink will be coming on, and so after Rosh Hashanah dinner and we're done with the prayers, we will have a Pink concert. Like, she lives right off of Piedmont Park. And then I had a doctor's appointment too, apparently. So my son last night, who's math and science oriented, was like, "So you messed up 4 times, Daddy?" And I was like, "Yeah, that math sounds pretty spot on." But it really came from the excitement of, it's an opportunity to talk at a place that, as a kid, these types of places were important to me, and I still enjoy it. We love going up to Chattanooga, and I had no idea there was a great kids' science museum there, and I did my training in Greenville, and again, there's like a great hands-on science museum there. So I was kind of tasked with, hey, can we talk about some sports injuries, because we've got this new Sportsology exhibit, and so had an opportunity to walk around, and it looks awesome, but I was also kind of thinking, like, what would be pertinent, because, again, I quad booked today, but this week has been the week of, like, double booking and triple booking, so I went to my go-to kind of PowerPoint, which is 240 slides, which we will not be going through tonight, but it's my go-to PowerPoint because it's kind of a conglomerate group effort between a couple of my sports buddies, but also some of my orthopedic, pediatric buddies. So when you do your 5 years of orthopedics, after your 4 years of medicine, a lot of us, over 90% of us, are now subspecializing. And so there's a pediatric route, there's a tumor route, there's a total joint route, there's a sports route, there's a foot and ankle route. But the pediatric guys actually don't get a lot of sports training. So a lot of times they're calling me saying, hey, what should we do? And a lot of times I trained where there was a Shriner, so I have a comfort level with kids, but sometimes I'm calling them saying, hey, what do I do when I got a 4-year-old in clinic? And so we've kind of stolen slides from each other. And so whenever I'm talking to the community or primary care providers or, interested youth, whether it be high school or even some med students and interns, this is kind of one of the PowerPoint decks I go to, and then I kind of cherry pick what is applicable. So as I was walking through the exhibit, and David was showing me, like, how high can you jump? I said, well, that's an Achilles maker, So, well, let's talk about things that are applicable. That's an Achilles maker, and then if you land funny, that's your ACL. And then the pitching machine was like awesome. I said, well, that's Little League shoulder, Little League elbow, that's Tommy John's ligament injury. We can talk about that. I didn't have any problems with the grip strength one. I don't think anybody's going to get hurt on that. And then the wheelchair one, that could be a nice rotator cuff maker depending on, the age group that decides to go for a race. So we got a couple things we can touch on. So every once in a while I'll pop off and find that section in my PowerPoint. So without further ado, let's get started. I am at PC Orthopedics. I started the sports medicine program at Northside back in 2016, coming from private practice in South Carolina, and did that for about 5 years, but really was always hoping to get to Peachtree. Those were kind of the guys I trusted, and all my second opinions went to those guys. So it was kind of a very natural transition after I finished my 5-year contract at Northside to seek an opportunity at Peachtree, and just got lucky that timing was right. And I've only been there 5 months, and you can tell how overwhelmed and busy I am, so it's good news. And so I'm a little bit of an odd sports medicine guy in that I do a lot of general orthopedics, and orthopedists in general see anywhere from 30 to 50 patients a day. I do my inpatient care at the Northside Hospital main campus. But one of my problems with the term sports medicine is when we were putting the name on our first clinic at Northside, I really wanted to say, orthopedics and sports medicine, is that it presumes that we only treat athletes or weekend warriors, and it's just not true. Like, in part, going back to that statement I said where 90% of us choose to subspecialize, the days of general orthopedics are gone unless you're really in rural somewhere, where, 30 years ago, the guy in East Cobb, who kind of had the community there, one day he might do a neck fusion, and the next day he might do an ACL reconstruction on a high school kid from Walton High School. And nowadays, if I did a neck surgery or a back surgery on any of you, the state board would have me in their office the next day saying, you did a sports fellowship, right? Like, that's outside your scope of practice. Your license, please, So sports medicine in many ways, where some sports specialists would say this is complete blasphemy, but sports, we train in every joint, including the spine. and every musculoskeletal tendon unit and nerve in the body. And so the truth is, we kind of are the next generation general orthopedists. And so you don't have to be a weekend warrior or an elite level athlete to say, oh yeah, I need to make an appointment with an orthopedist, and it's, who should it be? I think my mic there just kicked back on. And so that's one of my concerns in how we approach the community, because I always say I deal with diapers to diapers, the kind of the cycle of life, and it's because we're trained to do so. But a lot of sports orthopedists will say, no, I just do hip and knee, I do shoulder and knee. And the truth is, our training is incredibly broad. We get our 5 years of orthopedics, and then the 1 year I was at UConn, I did 850 cases in 1 year, and it's just drinking from a fire hydrant. And we kind of, we really are a first stop in terms of kind of a more holistic whole body approach to the musculoskeletal system. And then oftentimes I find myself, I'm directing care because you need a hand specialist, you need a spine specialist, where it does exceed what a sports surgeon is trained as. So sports really is kind of, I think of it as the new generalist, but cutting edge, where procedures used to be done open, now we're doing it what we call arthroscopically with a camera on beautiful 4K monitors. You can see the anatomy better than with your naked eye. And where procedures used to be an open incision, we can do it through 4 poke holes. The camera is smaller than the refill in your pen. And so we're just kind of the next generation of general orthopedists in my mind, but I know for sure that our previous chief of orthopedics staunchly disagreed with me and said that's blasphemy. We treat athletes, and it's just not so. And so and that's why when you look at the list of things I do, it really is from head to toe. And I have been very fortunate in my training experience where it has confirmed some specific specialties. When I'm not in the office, we're still working and building and putting screws in at home. We have this Barden team. I often like working with wood because it doesn't bleed and it doesn't sue. But this is what happens to cast material in my home here is we make swords and keychains. And the other thing is scrubs. We quick fishing outing after a surgery, scrubs are perfect for it because nobody wants to come home smelling like fish. So there is some time. We just have to make the time. And tonight I was not so good at that. And then also part of being an orthopedic surgeon and particularly sports, I do a lot of, this is a garage. I do a lot of garage splinting and casting. It's having me as a neighbor is kind of like, you don't have a deductible at my house. So we stabilize a lot of things in the garage and then get you in for an x-ray on Monday. And then perhaps one of the things I enjoy most, which we may get to some pictures of, is we're now at the age where we can't resurface a knee and give you new cartilage. We still are using metal and plastic in the form of a total knee replacement for that. But we are at the age where I can do cartilage transplants. And so someone in their 30s or 40s has a cartilage injury, they're not doomed to end up with a total knee one day. I can actually wait for someone who's been very generous and donated their body and actually take a piece of their femur and put it in the pothole in your femur, and that should last you a solid 30, 40 years. And so those are kind of the fun things I enjoy the most. And then, our life isn't just office. We get to, most of us, it's just kind of assumed that we do pro bono work in the community, usually assigned to a high school as an outreach program, where we oftentimes get to engage students who are interested in pre-med, or some of these high schools actually have athletic training programs, and so places like this are going to be great for some of those students to come by. And so every year when I was at the Walton High School team doc, we always start our season off at Mercedes-Benz, which the students loved. And there's also, again, you just have to find a way to make time. So I brought my son, and he would help fill up the waters and feel part of the team. And so we do everything. I do, elite level athletes, Division I, pros, all the way down to, this is my kid when he was in the bobblehead toddler phase, where you worry that their head's going to fall off their little teeny neck, to, some of the Hawks guys. So you never know between opening the door, who's going to be there. And in particular, I train under two colonels, retired colonels from West Point. So I do a lot for in particular, our servicemen who have retired. This here is Dr. Naldoni from, he's a family medicine guy in East Cobb, but he does guard. And once a month, they beat him up. And then every couple of months, he needs to see me to put him back together. Because he's in his 50s, but he is physiologically up here, stuck in his 30s. And this is a retired naval officer who helps take care of vets. And then a lot of times I will get these no-names, these kind of elite-level operators that they're given a state and city name. I never know who they are. They're sent to me because I train under Arciero, Colonel Arciero, and they want the Arciero ACL, they want the Arciero lateral ligament reconstruction, and so they go to sleep with liaison, so they don't talk. They wake up with liaison, and instead of having a 9 to 12 month relationship and clearing them to go out into the field, they disappear. I don't know if my repair worked or not. I'm not privy to that information. So sports medicine really allows you to do a lot of different things, and everybody's got their Yodas, and it's really not fair for me to give a presentation and not share where I got that knowledge. So this is Arciero. He's a pioneer of complex shoulder. The year you talked about UConn being, a heavy hitter when it comes to basketball, the year I was a fellow, both the men and women's won, but because I was the fellow, I had to stay back in Connecticut and mind the fort. And then Gus is my complex shoulder guy who's recently left and gone to Harvard. And then a real cowboy pioneer, John Fulkerson, he's the one that's conferred the patellofemoral, patella instability, dislocating kneecaps. There's a procedure called the Fulkerson procedure. This guy actually had since it's Rosh Hashanah, I'll use a Yiddish word called the chutzpah. He had the chutzpah, the gall, to say, you know what, this kneecap's dislocated. I'm actually going to cut their bone and shift it over and realign it so their kneecap gets to go back and forth straight. And everybody thought he was crazy. Like, that seems pretty radical. Well, 30 years later, it's gold standard. A lot of school teaching, things we're doing today. And then again, if we didn't get to play in the operating room. And this is really for a lot of surgeons, we enjoy clinic, but we're fixers, we're tinkerers, we're the guys who like to come here and play with this stuff. And so, for example, about the cartilage restoration, this up here, for example, is a piece of cartilage that we used to just be able to do little circles. Now I can do ovals and literally put that in someone's femur and replace a pothole. And I got a guy in the neighborhood that did his ACL and resurfaced his medial femoral condyle, and I watch him run on it every Saturday morning. And he can do that technically. It just hurts my heart because I don't know if he's going to wear this piece out, because this piece was perfect when I put it in. And we get to do a bunch of different things. You see shoulders here, you see knees here, you see a very tired surgeon here. But in the break room, when we get our sodas and coffee, orthopedic surgeons of all the specialties, we tend to be real happy. We like what we do. Again, more playing in the operating room, and then I know the other side of it too. So when I talk to people, I'm going on surgery number 13 myself. I've already had my rotator cuff done, so I've been on both sides of the knife. I just include this because I cover now, obviously, Georgia football, high schools, but this is South Carolina. I got to be honest, they grow them bigger there. So this is me. I'm 5'10". This is a sophomore. So he's on the line. He's on the sideline because they're waiting on him to quote unquote mature. He's not quite ripe yet. So that just blew my mind. And then again here, I get to bring my daughter as a little cheerleader, so I try to include them as much as possible. And we treat all types of people. So this might be the cliche. This guy is a competitive bodybuilder who unfortunately got this physique utilizing steroids, which is very bad for your tendons. And so he ruptured his quad tendon. And so after repairing his tendon, this is him asking me hey, when can I get back to lifting? But we see all types. And so that's what's fun, is you never know what's going to be behind the next door. And sometimes my athletic assistant, my is so good right now, she ruins it for me. She comes out of the room and says, oh, it's an ACL. I'm like, you didn't even let me get to examine him. And she's usually right. And then you get to do this is someone who had a seizure disorder. And they kept on dislocating their shoulder to the point where the shoulder kept on getting hooked on the socket here, and the socket just dug this wedge of bone in here. So of course, he's missing a big part of the ball, and this is the ball, this is the socket, and this is kind of the three-dimensional view. And so this is someone who was generous, and they donated their body to science, and I'm able to do a cartilage transplant. Looks like a grapefruit slice, and literally implant it there and give him a humerus so that his shoulder doesn't dislocate anymore. And even with the next seizure, he should be good to go. This guy is not an athlete. In fact, he's a recovering addict, and that's why it took him so long to seek care. Is when he finally got clean, he realized the shoulder was a big problem for him. So it can be rewarding in a lot of different ways, not just getting a black ops guy back and doing whatever he's doing that I'm not supposed to know, or a kid playing for high school football. I think we talked about that. I think, I said I was going to cherry pick what topics I was going to choose, and I think, if I had a bunch of 8 and 10-year-olds in the audience, we'd be talking about Little League shoulder and Little League elbow, and where I'm in East Cobb, they're playing year-round, and these kids are getting used up, but I see a lot of people over 40, and so I think we'll start actually where this next slide is, and talk about upper extremities, which I think all of us know a friend who's had a rotator cuff tear, who's had tennis elbow, and these are quote-unquote sports medicine injuries. These are treated. These used to be treated 30 years ago by your general orthopedist, but now they really fall under the purview of a sports doctor. And so these are a couple of things we can talk about today. I think what might be most fun is to talk about impingement, rotator cuff tears, some of the AC dislocations we see in athletes. A lot of us, whether you know it or not, if you feel into your bra strap, that little bump right there is arthritis of your AC joint. May not bother you, doesn't bother you, we don't mess with it. But most of us had it by the time we're 40. And then we'll talk about one more thing that we can add to the burden of being a woman that men get to escape. We'll talk about frozen shoulder. And then our medical term is lateral medial epicondylitis, which is your tennis and golfer's elbow. But yeah, this in particular, this is actually a passion of mine. And when I'm old enough where it's the right time for me to hang up the knife, this is where I'm actually going to focus my research time on. So impingement syndrome is very common, and impingement is our fancy way. Everything medicalese, we've got to make it sound more sophisticated. Impingement is pinching. Okay, and so it's pinching of the rotator cuff, and so people call it the rotary cuff, but we call it a cuff because it's several tendons around your shoulder. This big meaty deltoid will get you to about 90 degrees here, about 90 degrees here. But if you want to go up higher, these 4 little chicken tenderloin muscles, a couple of which are fused as a cuff of tendon, that land on the ball and then hoist the ball the rest of the way. And so when it gets hoisted, sometimes it can hit It can hit the roof of the shoulder. And some of us are built differently. Sometimes we have a flat roof, kind of like this person right here, but you can see how if this was hooked downward, this is a tendon, it would very much be getting pinched by the roof. And that's what we call impingement. It oftentimes is impacted by posture, and so we don't always bust out the knife. A lot of it is non-operative management, but impingement can also lead to rotator cuff tears, in part because people oftentimes in their 50s, 60s, they say, well, what did I do wrong? Why did I get a rotator cuff tear? It's interesting how many times patients want to blame themselves, whether it was lifestyle or they picked up that bag of mulch that they knew was too heavy, they shouldn't. And the truth is, it's life on earth and gravity, and our parts are probably warranted for about 40 years, The time of Hamilton, which wasn't caveman era, where New York City had streets and horses and carriages, and the wealthy had indoor plumbing. The average lifespan was 43. That's if you survived the measles, mumps, rubella, pediatric spike. And so just the way we're made, it's unfortunate, but there's an area in the rotator cuff that doesn't have a lot of blood vessels. So if that area is getting pinched and pinched and pinched every day, there's a little bit of trauma with life, and there's really not much of a healing response. And eventually those fibers just give up, and it's not your fault for lifting that bag of mulch. It could have just happened on a Tuesday morning. And that just is life on earth and gravity. And there's different ways in the office that even without, we're very fond of our advanced diagnostic imaging with MRI and CT and 3D views, but a lot of what we do is physical examination. And then the advanced diagnostic imaging, we order if we want to confirm the diagnosis, but really only if we're going to act on it. There's no point. We write the order, but it's your money. And so I don't need you to spend your money on an MRI unless that MRI is going to help me change my treatment plan. And so if you spend enough time in residency and fellowship learning how to examine someone, those advanced tools are great, but a lot of times the diagnosis is already made if you've got a good diagnostician, a good clinician that takes the time to lay hands. And unfortunately with American healthcare these days, there's less and less time for doctors to lay hands, and there's much more dependency on advanced diagnostic imaging that unfortunately not everything you see needs to be surgerized because it may not even hurt. So I just left this up. This is a bunch of medicalese, but just to emphasize the neuromania of orthopedic surgeons, I trained under Hawk. Hawk trained under Neer. The two impingement maneuvers to test for impingement. You do the Hawk maneuver, and then Neer is like the grandfather of the shoulder. If you have a positive Hawkins sign and a positive Neer sign, where we basically take your rotator cuff and try and drive it up into the roof and say, is that your pain? Then it's impingement. And these guys named it after themselves. So I always said if I ever invented something and I got a couple things cooking to make life easier for the residents, it was just going to be called what it is. There's never going to be a Barden in the name of that procedure. It'll just be called what it is. And that's how you'll pass your test, is if you remember what the procedure is. So we do think certain people are prone to impingement. When people say, why me? Well, some people have a flat roof. This here is the socket, which you'll notice is rather flat. Unlike the hip, which is like a cereal bowl, the shoulder has the greatest range of motion of any joint, in part because the socket's more like a saucer. So that ball can really go almost wherever it wants, which can be good but can be problematic because it can also start to migrate up if your rotator cuff's weak. And if you got a flat acromion, may not be a problem. Acromion is the roof. Some people are type 2 where they have a little hook. And some people, I call it the vampire tooth, they have this spike where for 30 years, that rotator cuff has been digging into a spike, and those fibers eventually give up. So whenever we're in there fixing a rotator cuff, we make sure to take, really, it's just a medical sterile Dremel to flatten out this bone and make them a type 1, so they're less likely to re-tear and ruin all the hard work we did. And this is something we see, especially where I'm in East Cobb, where tennis is like blood. I'm sometimes afraid my kid's going to run on the court because I'm convinced that 65-year-old woman will cut him if he interrupts her serve. Well, the serve is all overhead activity, so that's, and with a lot of force, that's a lot of impingement. And if you've got a vampire tooth sticking in that cuff, sometimes you're just going to be more prone. It is, if that's all you have and you don't have a rotator cuff tear, sports surgeons tend to be very hedonistic. So a lot of other things, spine could be a 6-12 month recovery. You go in, takes 20 minutes to shave that down through a poke hole in the back for the camera, a poke hole on the side for your medical Dremel, and they're back playing tennis in about 2 months, and you've got a happy patient, and you send them on their way, say, go live your life. It's incredibly satisfying for both the patient and the doctor. And again, these are just some of the maneuvers that, again, if we lay hands, we don't necessarily need an MRI. And a lot of times, you don't have to get surgerized. There's good data that says, hey, if you let me give you this little injection, you may have friends that go for their cortisone shot every couple months, it keeps on going. It's basically, systemic. I get very frustrated when primary care docs dole out, like if any of you have ever taken a steroid dose pack, that's systemic. That increases your blood pressure, your blood sugar, water retention, irritability, insomnia. It's very bad for bone health, can cause osteoporosis. Whereas when we give, a lot of people think, are these sports docs, if I go, he's going to come at me with a needle. It's not that we're needle happy. It's just that I can liquefy. I tell people it's like if I could liquefy a 5 milligram prednisone tablet, which if you took orally really wouldn't help any of your aches and pains, but For a shoulder joint, it's a pretty high dose, and all of our joints are wrapped in like this thick Ziploc baggy sinew, if you will, called a capsule. 95% of that little 5 milligrams stays there, and so it can make a profound impact without impacting your systemic organs. And so that's why injection therapy is a big part of sports medicine, especially if we're trying to keep people out of the operating room. Now, it can be used unethically. There are some high school team docs that will inject these 16-year-olds with steroid, which I find absolutely appalling. But for those who, it's medically indicated and are age appropriate, it can keep them out of the operating room, restore quality of life, and keep that 65-year-old playing tennis without chasing my son down. And so it's really just a simple injection like this, and usually spray some cold spray, and people, the numbing medicine, by the time they're at checkout, they say, ooh, I like this. And again, immediate gratification. That's sports medicine. That's what we want. And this is kind of what we're doing in surgery. If someone has impingement, where they come back 6 weeks later, they say, Ben, that injection was awesome. I played X many matches and doubles, but now I can't sleep at night. I can't wash my hair. I can't reach behind my back for my bra. And those are all impingement signs. And if they fail conservative treatment, I say, look, we have a surgery with less than 1% risk of infection and a satisfaction rate over 95%. It's archaically simple. I go in there with a Dremel, and we turn a type 3 acromion with the vampire tooth, and we level it flat. And please don't wear the sling for more than a week or two. It's going to make you stiff. And they do some PT, make sure they don't get stiff. It takes about 6 weeks just for me mucking around in there for the inflammation to calm down, and then they're really happy. And that's probably one of the most common orthopedic things we see. In fact, that's one of the things when the orthopedic comes out of the room and talks to their assistant, they say, impingement again, because it's just part of being a human, in gravity on Earth. I like to tell my patients, like when they say, why me? I say, life on Earth and gravity. I don't know where the rumor started that was an easy thing, but life on Earth and gravity is not easy, and gravity doesn't take any breaks. It'll cause breaks, but it doesn't take any breaks. So next thing is, actual rotator cuff disease, which we start seeing, like me, as early as the 40s, which is more traumatic, when I thought I could get a 4x8 piece of cabinet-grade plywood up above my head. This is the guy operating on you. That was my judgment call when I was inside and could have helped. So I went up with the plywood. My shoulder said, that's funny, and came down and tore part of the biceps. Actually, the biceps is 2 muscle groups, a short head that attached to the coracoid. Never have any problems with this guy. This guy, oftentimes we do. And so I tore my long head of the biceps, which anchors on the socket inside and becomes part of a bumper system, and tore my rotator cuff. And so even before I was a part of Peachtree, I knew who I wanted. I was one of the partners there. I called them up from the MRI center because they knew me there. They let me come around, look at the picture. I said, ugh. So by the time I was in the parking lot, I said, you got time for me? This is what I got. So it's not uncommon to get this. In fact, I tell people, again, when they say, why me? I say, if you're lucky enough to live to 80 years of age, 80% of us will have rotator cuff tears. And we've got all different types of classification systems, whether it's partial thickness, full thickness, the size of it, whether it's a crescent shape, whether it's a triangular shape, acute versus chronic or traumatic in my case. But I wanted to show you this picture because one of the reasons that these tears happen is this is looking through the back of a shoulder, and this is the ball, and this is white, shiny, smooth cartilage. So when you hear about people having arthritis, it's where they've lost this, whether it's in the knee, the shoulder, the big toe. This has eroded away, and there's bone beneath this. This is the rotator cuff. It's not even pink. It's white. It doesn't bring anything to the healing party. So over time, as this takes trauma, there's not even any blood vessels to bring restorative nutrients and supplies for the cells to regenerate. And so over time, it accumulates enough trauma, and like I said, it could be a Tuesday, and all of a sudden you can't lift your arm over your head, whether you're an athlete or not. So as I was walking around the exhibit, one of them is hanging from the bar, which, as a timed thing, how long can you hang from the bar? And you'll have an 8-year-old probably up there for 10 minutes. But if your 5-year-old dad tries it, he may end up with this, where the rotator cuff fibers have detached from the bone, and they're just sitting out here in the breeze where they should be anchored to the bone, where they could be a motor. But he chose to hang his 200-pound body off of that exhibit bar, and the next morning he thought it was nothing, a little bit sore, but 2 weeks later he can't sleep, he can't wash his hair, and he's got an appointment with Dr. Barden. And so there's lots of different tests we can do. And then the good news is if it's a partial thickness tear, like right here, let me go back, I'm sorry. Some of the non-operative sports medicine doctors, these are people who are pediatricians, internists who chose to do a year of non-operative sports medicine. They're very talented with ultrasound, and they can actually sometimes visualize in the office if you've torn. As a surgeon, we oftentimes detect tears based off of weakness from certain maneuvers we do to isolate one of the 4 major tendons. And then if we're concerned, we get an MRI, and sometimes it's a full thickness tear where here's the stump and here's the other stump. And normally this would be a motor that would lever this way and give you overhead activity. And you can see this person has a pretty flat roof. So this is really just a degenerative process. You know, it wasn't even that their morphology, their bone structure made them prone to it. I'm going backwards. And this is just some of the data I was saying that if you're lucky enough to live to 80, you're going to have a rotator cuff tear. But I always tell people in my office, particularly those, my 76, my 77-year-olds, unless they're these, people that are just, they amaze me. They're still playing tennis every day, golf on the weekends. I always say, did you see the waiting room? There wasn't a bunch of 80-year-olds waiting on their shoulder scope. Because the good news is a lot of times when we're 80 years old, we're not chasing around toddlers. We're not hitting the gym, bench pressing. Our demand is lower. And so what we demand of our shoulders is less. And that's good because that means that physical therapy to strengthen up the remaining rotator cuff muscles. Maybe you need a cortisone injection to actually facilitate physical therapy because you're so uncomfortable. But a lot of times, in fact, a new study came out of Europe about 6 months ago with rates as high as 86% success in terms of functional improvement, pain improvement, and something that orthopedists are finally paying attention to, especially in sports medicine. Sounds crazy, but quality of life score. Yes, it's very objective. Like, how do you put a number on that? But you may not have full range of motion, but you say, hey, how you doing? How's your day? Do you feel limited? Are you sleeping okay? And people are saying, yeah, I'm doing my grocery shops, I'm getting dressed, I'm happy. Their MRI shows they got a big unrepairable tear. And more we're putting emphasis on, quality of life outcome measures instead of, okay, they only have 90 degrees of forward flexion. Well, they may only have 90 degrees of forward flexion, but at 85, that may be all they need to get through a day pain-free. And so you don't go operating on those people. And that kind of comes into the art of medicine, too, is deciding who needs surgery, who doesn't. And a lot of times injection therapy is utilized in this if it's partial thickness. If it needs to be repaired, we can do it through 4 little poke holes. And like I said, the rotator cuff brings nothing to the healing party. So we cheat and we take a little Dremel and we roughen up the bone and we get some bleeding bone. Blood is life. And I actually go one step further. I drill, if you can imagine a drill bit as thick as a paper clip. If I can just drill 4 millimeters deep, I get access to bone marrow elements, which is, we just scrape the bone, it's the same blood that's in your veins, But if we poke a couple holes in the bone marrow, we get tremendous growth factors present. That is kind of probably next generation orthopedics. I don't know if it'll happen in my lifetime, but you see a lot of heavy marketing now for orthobiologics, injecting stem cells, hoping to regrow cartilage. And unfortunately, right now, it's a lot of false advertising, frankly. Our international academy is going after a lot of these places because it's all cash pay. And the reason it's cash pay is we don't have the data to prove to insurance that, hey, we can do this for $1,000 and it'll save you from paying for a $50,000 knee replacement. And the insurance companies would like those numbers, right? But we don't have the data to prove it. So we roughen up the bone, and then it's dealer's choice. The doodads we have to reattach that tendon to the bone have changed over the years. We used to literally use titanium and metal screws. Now we're using combination of either inert peak plastic screws, all suture screws, which are pretty cool, where they, You drill a hole, you put a suture down there, and as you pull it back, the suture diameter thickens bigger than the hole, and you can pick the person off the table just from this suture. And that's really nice because if you ever have to go back and do a revision, you can drill a fresh new hole. You're drilling through suture that's been totally incorporated by bone. And so this is kind of what a repair looks like, where we're preparing the bone. This is one of those old school anchors I was telling you about. But we do it through a poke hole. This cannula is about 8 millimeters in diameter. And then the camera oftentimes is looking from the back. And then those of us that have trained probably since 2006, Gus Mazzacca, my Yoda that was up here that went to Harvard, he helped pioneer this technique called the double row technique, which has proven to be mechanically superior to older techniques where we call the parachute technique, where we pass a bunch of suture. Now this is high tensile suture. I did a Achilles rupture this morning, and it cuts me through the glove as I'm tying the knot. The glove doesn't break. It's just, it invaginates in the little creases in my joints, and it's that strong. I'm 260 pounds. I could hang from the ceiling off of one of these, and he's got 4. And so the limiting factor here, if a rotator cuff's going to fail, is actually not our doodads. Is the knot going to pull out of the tissue because the tissue's old and beat up. But this has allowed for earlier rehabilitation protocols, getting people moving sooner. But again, you see here in a real video, like there's some pinkness here as he gets close to the muscle, but this is the tendon and it's white. So we're really dependent on the underside where we've roughened up the bone to bring some healing to the party. So let's go real quick over some AC injuries. This is your run-of-the-mill AC joint arthritis, which happens regardless of your activity and lifestyle. And for a lot of times for women, I can tell you can locate it. It's usually right underneath the bra strap. And we only mess with it if it bothers you. And again, one of the most gratifying surgeries, we shave about 7 to 10 millimeters off this bone, and you love it. I loved it. But that comes with age. Now, there is such a thing as a traumatic AC joint injury. In fact, in the National Hockey League, if you don't have a bump, not like the bump you ladies may feel under your bra, but an actual deformity where you've torn part of you've actually torn part of the ligaments that hold the roof of the shoulder to your collarbone. 84% of NHL hockey players have, it's a horrible name, they call it a shoulder dislocation. Separation sounds barbaric, but it's just an AC joint injury. But I also oftentimes wonder about the 16% of guys that don't have the bump, if the other guys are judging them and being like, you're not hitting hard enough. Because everybody else in this locker room's got a bump, but you. And I'm going backwards, hitting the wrong button again. And then there's different degrees, just like everything. Some need surgery, some don't. In fact, the technique that was designed to repair these and reconstruct these two ligaments, the conoid and trapezoid, was pioneered by, guess who? Gus Mazzacca, my shoulder mentor. So the Mazzacca technique is the gold standard when we actually have to repair these. And here's like one. This is one that a typical high school student will get, where they've torn that capsule that connects the roof of the shoulder to their collarbone, and their collarbone pops up a little bit. So that NHL player is walking around with this bump sticking up out of the skin, but this is a non-surgical one. We only have to reconstruct the ligaments if this is, fully displaced 150%, it's distant. So it would have to, the bottom part would have to be out here, or it's actually poked through the trapezius muscle, in which case you can't leave that. Let's see if I can get this to advance a little bit more. And we'll find something fun to talk about. So this is the Mazzacca technique with the ligament reconstruction. And I was so angry, I couldn't remember one day, does this limb go in front or go in back? And to try and represent the anatomy, because one ligament does tend to anchor more on the front part, and one conoid or trapezoid anchors on the back. And so right before the surgery, I called Gus. I said, it's killing me. I can't remember which way do you crisscross, front over back or back over front. And he used to call me baby just to make me angry. Like Bruce Springsteen, I think, used to do that. And he said, baby, he says, I don't even cross it anymore. I said, since when? I haven't seen a journal article. Since when have you stopped crossing it? And so I went back to his original article and crossed it the way he trained me to do it. Let's see what else we can do that's fun. And if someone's watching time, just let me know, because I know, let's leave at least 15 minutes for questions. But usually in hockey, it happens when these guys get taken down to the ice or when they get slammed into the boards, is when that shoulder out here takes a load. The boards or the ice is pushing this part down. The clavicle wants to stay up, and the ligaments here, here, and here give up just under the tremendous load. Let's see what else. Shoulder dislocation. Anybody got kids playing baseball? Show of hands, anybody? Okay. Sometimes Little League shoulder is a big talk. This is something I am going to talk about just because I'm selfish, and this is a personal interest of mine. Shoulder dislocations are more common than you would think, and it can happen. I saw a woman the other day, her husband was trying to help her and pull her out of an Adirondack chair, and I don't know how strong her husband is, but the poor woman had her shoulder pulled out of socket. Just having her lovely husband trying to help her get up out of those Adirondack chairs are, deep cedars. And what primarily prevents it is, again, I talked about that soft tissue capsule around it. The rotator cuff helps keeps it centered. And so this is a picture of, this is the ball. Oh, let me get that laser. This is the ball. The socket's way back here. So the most common form is where it dislocates out the front and down. And usually to do that, I told you that bicep, one of the biceps sneaks into here, it lands on top, and it forms this bumper. It kind of reminds you of when you were bumper bowling, and it's kind of like that bumper all the way around, and that helps kind of control the ball from sliding around too much. And so usually, unless you're a really loose ligamented Division I volleyball girl, most men, if they're going to dislocate, or women certainly in the 30s and older, the only way they can do that is if they rip off that bumper. And while it is a surgery, again, it is one of those very satisfying surgeries. And so this is a great picture here. So here, this is a patient laying on their side. Okay, so their head's up here. This is their left shoulder. And so this is their socket kind of laying parallel to the floor. This is their ball. And one of the reasons their ball's been able to dislocate is that this bumper, see here, like that's why it reminds you of bumper bowling. Imagine this running down the gutter on either side. Your bowling ball would not be able to get over that. This is where it's been torn. And so the ball can just kind of flip that out of the way, and people experience recurrent dislocation. And again, Arcero, my shoulder mentor, he's the one that did the most of the research, said, hey, if you're a 25-year-old male involved in contact sport, you've dislocated once, you're at an 80% risk of dislocating again. So I see a bunch. I've got a dirty dozen. They're in their 60s. They played high school football, no chance of ever playing Division I or pro. But back then it was, hey, put the shoulder back in. When he's feeling better, put him back in. And those guys ended up with horrible arthritis, and they're waiting on their shoulder replacement. But unlike knees, we can't do shoulder replacements till people are in their 60s or 70s. Because unlike knees now, which last 30 years, we're on our fourth or fifth generation as opposed to our 30th generation of total knee design. And we hope to get 15 years out of a shoulder replacement, maybe 20 tops. And so, and unlike the knee where you can swap out parts and revise, the shoulder is very hard to revise. So we try and keep them comfortable and functional until age where we can say, look, we're going to give you a new shoulder and it's going to be one and done. In the meantime, what we can do for younger people who don't have cartilage damage, now the rules have changed where if you've dislocated once, then and you're under 25, I'm fixing you. If you're in season and you're trying a scholarship, then we'll try our best to rehab you. But if you dislocate again, you're going to have to go doctor shopping because I'm not going to clear you for sport because I don't want you part of my dirty dozen.
I just wanted to interrupt real quickly. If you have tickets for the 8 o'clock planetarium show, we're about 5 minutes to 8. So
okay. So if you want to open up the questions, we can do that now.
Okay.
Because I could.
All right. Since we're recording this, I need to come over with the microphone so not only everybody can hear you, but also.
Oh, so the fact that I missed my son's birthday and everything is now
yeah,
part
it's
of
permanently
the
recorded.
part of the
So
video record. Wonderful.
I'm going to come back over here.
Wonderful. I was hoping he'd forget, but now there's evidence.
Okay, with your cartilage transplant, is that only for in the 30s or 40s, or can you do that for someone that's older?
So that's a great question. So one of the first lessons I teach the resident is you treat the patient, not the picture. So you may have a 70-year-old, and you come out of the room and you present it, and you say, look, this woman's 70 years old, but she appears younger than stated age. And some people are just blessed with physiology where a lot of 70-year-olds show wear and tear in their knee. In which case, if you already have arthritis, putting in just one little, oval of new arthritis, unlikely to really, significantly impact your arthritic symptoms. But if you've been, blessed with great genes and you didn't abuse the knee and you didn't use tobacco products, which tend to degrade cartilage faster, then they're the minority, but certainly I've done cartilage transplants on 70-year-olds where it used to be, well, we'll give you a total knee replacement, or it's just part of your knee so we can do a partial knee replacement. But metal and plastic doesn't feel like you. And so although there's high satisfaction with it, there's much higher satisfaction if I can just put in a piece that matches your piece and it doesn't feel like metal or plastic or clunk or click. And so the truth is, more and more in orthopedics, where there used to be hard cutoffs, you don't do hip scopes in people over 50, period. Realizing, no, it's much more criteria and patient specific. So if you're a 70-year-old and you have grade 1 out of 4 wear or grade 2 out of 4 wear, then you're a candidate for something like that. If you've got diffuse areas where, for example, 4 out of 4 wear is where you don't have any cartilage left, it's just bone. And by that time the bone's stressed out, it's making bone spurs, then no, that's not gonna work. That's the wrong procedure for you. We need to resurface it with metal and plastic in order to give you, restoration of function and reduction in pain, improve your quality of life. So more and more, it is more patient specific than these just indiscriminate cutoffs.
Our daughter played softball when she started when she was 9. She's 38 now. We found out that she had hyperextended joints. And now that she's 38, she feels like her hip is coming out of its socket, and we think she might have a connective disorder, tissue disorder.
So it's generalized ligamentous laxity is very common to young women, especially once they start cycling, because the progesterone and estrogen, they may have already been flexible, but now every month they're getting large peaks in progesterone and estrogen, and so they usually have party tricks where they can touch their thumb to their forearm. They have more than 5-10 degrees of hyperextension of their elbows, where the elbow actually goes out this way and that way, same with their knee. And the hard part is to distinguish, okay, are you a teenage girl with ligamentous laxity because you're XX, you're a female, and you're cycling, and you've got hormones that the same 15-year-old kid doesn't? Or do you have a connective tissue disorder like Ehlers-Danlos or Marfan's? And so back when I was in medical school, there was 3 types of Ehlers-Danlos, and now they're up to 12 or 13, and now there's this whole thing where it's look, we don't have an exact genetic marker on it, but based off of clinical criteria and how flexible you are, yes, this kind of fits the medical picture of someone that has pathologic ligamentous laxity, which oftentimes those patients are at risk for dislocation, or in the hips, what's oftentimes happening is, because remember I said the hip is like a cereal bowl. It's really deep, and it's like a softball. It's oftentimes the example I give of the femoral head. So it's got a lot of constraint around it, but people that have loose ligaments, because the hip really does have these very thick ligaments around it. It's not just like a loose Ziploc baggie. It's this thick white sinew. As our experience with hip arthroscopy and being able to stick a camera in the hip and actually look at it dynamically as it moves, there is such a thing as hip microinstability. And there are procedures now where we go in and, usually people like that who are so loose, they haven't torn the labrum in their hip, kind of the equivalent in the shoulders, the same thing in the hip, because they're so loose that they don't push on it that hard. They can actually kind of jump the curb without tearing it. And what we do for them is we call it plicating their capsule. So we'll cut that capsule open, that thick sinew capsule, and instead of just sewing it back together, we do what's called pants over vest, is we take some of the slack out of it, and we overlap it, and we tighten it. And it's usually very successful. It's a hard diagnosis to make because a lot of it is subjective complaint. There's a lot of people that say, hey, doc, I feel like my hip's coming out. But you have to remember that if they do have something genetic in etiology like Ehlers-Danlos, their tissue is what their tissue is. So we can tighten them up, and they may love it for 3 years, but then their collagen is their collagen, and it'll loosen up again. And so that's one thing we're struggling with, is we see it a lot in volleyball players, softball pitchers that have a tremendous arc of motion, and they start getting loose, and we tighten them up, and they do great for their junior, senior year in high school, and by sophomore year at UConn, we're tightening them up again, because we can't do anything to actually influence the genetics that are making their collagen. So that's, that type of level of hip specialty, there's a couple guys in town that do that. So there's a physician named Dr. Willimon out of CHOA, Children's Healthcare of Atlanta. So it's kind of weird, you're waiting in the waiting room and you're seeing all these kids, but he trained under, there's about 3 kind of godfathers of hip scopes that have pioneered it since really late 90s, early 2000s is where we started realizing this is real, this isn't a fad, we can make people better. So Philippon out in Vail, Colorado is one of those kind of pioneers. And so Cliff Willimon at CHOA trained under Philippon. And so he's often that person. I do regular straightforward hip scopes where, just like here, you see the labrum's been sewn back down to the socket. We can sew it back down to the socket of the hip. But when it comes to kind of figuring out hip instability versus also, there's such a thing as called hip dysplasia. Is someone experiencing kind of slipping inage and outage, not full dislocations, but we call subluxations because they have loose ligaments, or do they have some hip dysplasia, meaning their socket may not be so deep. And he's probably one of the best in town for that type of level of complexity. And then in our group, we have a very talented surgeon, Dr. Dominic Carrera. But as amazing as Atlanta is in terms of the medical destination with Emory and PC Orthopedic's been around for 70 years. Resurgence has 120 doctors. There's a lot of talent here. That is like a niche within a niche, and so a niche within a niche, if you will. So I usually send those type of patients to Dr. Carrera at Peachtree or Dr. Willimon at Children's Healthcare of Atlanta.
And we've got one last question right here.
Hi. So my mom and my sister both have dislocated. My mom's dislocated her shoulder a couple of times, and my sister both of her pinkies twice. My dad's kind of always just popped them back into place. Do you recommend that, or is that something that's just no, you should probably definitely see a specialist for that kind of thing?
So the popping it back into place?
Yeah.
Yeah, so if you're able to do it on your own without horrible, pain, it's usually best done as soon as possible. That's like for football, when a football athlete, high school level, dislocates, that's when we stop the clock, because my opportunity to reduce them is about a 3-minute window and get them back in before their muscles spasm, and I have to bring them to the hospital to sedate them to get them to relax so that the muscles relax and I can put the ball back in its place. So in those types of acute situations where there are children who are very used to their kneecap dislocating and they know exactly what to do, they go straight and they push inside and they do it, that's the time to do it. If they wait, then they have to go to the emergency room. So, but if it's a recurrent instability issue, then that ultimately needs to be seen, because you worry that with recurrent dislocations, you're creating recurrent damage to usually we're worried about the cartilage of that pinky joint, we're worried about the cartilage of that shoulder joint, which, like I said, back in the 90s, it was yeah, once he's good, put him back in, and now we have a whole instability index that says, no, don't put him back in. He's at 80% risk of this happening again. That's unacceptable. Every time he comes out, he's going to hurt more cartilage. The only exceptions we make are sometimes we understand there's high pressure on these kids where, college is expensive and football is their passion. And we'll try to rehab them and see if we can get them through the season and see if the scouts want them. But if it happens again, then they need to be fixed in season. If not, then a lot of times they get their, Division I contract, and we fix them before they go away to school, usually over winter break. So they have 6 months to recover, so they show up to training camp ready to go.
Well, Dr. Barden, thank you so much for your time tonight.
Problem.
And thank you so much for being here and under duress from your family.
Oh, it's fine. It's
was
my
fascinating
wife
time.
said the best lesson to my son was that if you mess up, you own up to it. And so I owned up to it, and he was gracious, and he said, "Daddy, we can go to dinner Sunday." So we'll be
So
fine.
thank you so much.
No problem. I'm going to leave some cards down here for me, but also if you have any questions for the practice, like, for example, someone